So today we are welcoming Dr. Keith Fargo and Julia Wood, and they are both involved at the Lewy Body Dementia Association, Dr. Fargo as the Director of Scientific Initiatives, and Julia Wood as the Director of Professional Community Education. In addition to their work at the Lewy Body Dementia Association, Dr. Fargo has also led the growth and expansion of several programs to advance Alzheimer's disease research and treatment. He led the team that produced the Alzheimer's disease facts and figures, a very trusted source of vital statistics for researchers, policymakers, and families. Julia Wood is an occupational therapist and international presenter specializing in Parkinson's disease and related dementias, and co-authored the first American Occupational Therapy Association practice guideline for adults with Parkinson's disease. They are both passionate advocates for patients and families, and we are grateful for their work in raising awareness of these often misunderstood conditions. So thank you for being with us today, for your time and your expertise. I am going to mute myself and turn over the slides. I think we're going to start with Julia's.
Yes. Hi, everyone. Thank you so much for the kind introduction. I really appreciate the opportunity to be here with you all and share this information. So today we're going to talk about Lewy body dementia and unravel the complexities behind it. And then Dr. Fargo later on is going to talk about some of the new and emerging research that we're seeing in biomarker insights. So I'm going to tee it up for him, and then he'll give you the juicy stuff. So our learning objectives, you'll notice here, we're going to talk about how Lewy body dementia is different from Alzheimer's and Parkinson's. For some of you in the audience, this might be information that you already know. We're just trying to really set a level playing field here. We're going to also, as I mentioned, delve into that role of those emerging biomarkers and how they're transforming the diagnostic accuracy and disease monitoring and potentially even individualized treatments. And then we're going to talk about the current and future research directions in biomarker development. So I'm going to start you off and lay the foundation in how we can really understand this condition better. So, as I'm sure you all know, Lewy body dementia is just one type of dementia that falls under the umbrella here. Alzheimer's disease, of course, is the most common and the one that we hear the most about. Vascular disease is second, but you'll notice there, as far as our, neurodegenerative dementias, Lewy body dementia is actually the second most common, and we often say that it's probably the one that is most common, but that you've likely not heard about. So it accounts for, estimates show, about 10 to 25% of dementias at 1.4 million people living in the United States. And I think a lot of the misunderstanding about it comes from this. It's not only a complex disease, but it has a very complex nomenclature. So you'll notice here that there's a lot of different terms that you might hear: Lewy body disease, Lewy body dementia, dementia with Lewy bodies, mild cognitive impairment with Lewy bodies, one of my favorites there, diffuse Lewy body disease. For today, we're going to try to simplify and just really focus in on the nomenclature around the specific disease. But I just wanted to kind of point this out, that I think a lot of times there's confusion amongst many people based around a lot of the different terminology that's used. So some statistics, like I said, it's a very common form that a lot of people haven't heard about. Research suggests it's the most misdiagnosed form of dementia, and we'll get into that later. And then also studies indicate that it's the most expensive form of dementia, and I'll be talking about some of the factors that we know contribute to that as well. So we went through one umbrella, right, of dementia, and then how Lewy body fits under it, but then we've got another sub-umbrella here. So when we talk about Lewy body dementia, or LBD, it actually covers or encompasses two different types, or different subheadings, you could say. So in the case of Parkinson's disease, we recognize that if people live long enough with it, studies suggest about 50 to 80% of people go on to develop dementia associated with it. So for someone to be diagnosed with Parkinson's disease dementia, or PDD, they have to have those motor symptoms or that Parkinsonism first. And then the dementia comes along at least a year or more after. We call that the 1 year rule. And so you can think about it's like a chicken or egg. Parkinson's comes first, it's Parkinson's disease dementia. In the case of dementia with Lewy bodies, the dementia comes first or at the same time as those motor symptoms or that Parkinsonism. And for some kind of a rare subset of people with DLB, the Parkinsonism may not happen at all, or they may not have many motor symptoms. So, this is where a lot of the confusion can come in. And keep in mind that there's a lot of controversy and continuing dialogue about this nomenclature as well. But this is currently now where it stands per the criteria. So, how is this diagnosed? Well, in the case of DLB here, it's considered clinically probable if they have that spontaneous Parkinsonism, so the tremor, the rigidity, the slowness of movement. If they have REM sleep behavior disorder, fluctuating cognition, and or fully formed visual hallucinations. So you'll notice that they need dementia, which is just those cognitive symptoms that impact independence, plus two of these core clinical features to be able to diagnose. You'll notice at the bottom that now we do have some different indicators, right? There's a DAT scan, which looks at the brain's ability to uptake dopamine. And then there's a polysomnography and an MIBG. These are not, especially the MIBG is not used so much here in the United States, somewhat, but pretty rarely. And you'll notice they can have dementia plus one of these core clinical features. So like they could have a positive DAT scan, and then maybe they have one indicative feature, so they could have one of these indicators as well, and then one of the symptoms up at the top. So that's typically how it's diagnosed. So it's kind of a combination of either the clinical features and an indicator, or just those core clinical features. So it's still very tricky to diagnose. So it's under-recognized on average. I think because of the complexity, it takes around 18 months and them seeing 3 physicians to get a correct diagnosis. And like I said earlier, it's believed to be the most expensive type of dementia. In the case of Parkinson's disease dementia, it's really important that we continue to screen and monitor cognition. When James Parkinson wrote the essay on the shaking palsy many, many moons ago, it was thought it was just a motor disorder. He actually thought there were not cognitive symptoms associated. But like I mentioned earlier, we know now there's a very high incidence of dementia in people with Parkinson's, and the risk is actually 4 to 6 times higher than those without Parkinson's disease. And for many folks with Parkinson's disease, they may not go on to develop dementia, but they often have a stage of a mild cognitive impairment that can precede the dementia as well. So a lot going on here cognitively, not just movement or motor disorders. So then if we want to contrast it from Alzheimer's disease, right? We think of Alzheimer's as having those prominent memory problems or that amnestic presentation. So it affects the ability for people to store new information. And then we see those gradual changes to thinking and memory and behavior even over time. And physical symptoms might happen in later stages. In the case of Lewy body dementias, memory is mostly spared at the beginning. We do see some short-term or working memory issues associated with issues with attention, and I'm going to show some more about that in a moment. One of the hallmarks that I'll get into today is this fluctuating ability to think and remember. So, someone might be really alert one moment, really zoned out the second. So it's kind of something we see specifically with these Parkinsonian dementias. We see more commonly issues with problem solving, like executive function, attention, and reasoning for folks with DLB compared to memory. And those physical symptoms, like I mentioned earlier, that Parkinsonism may be present at all stages of the disease. And then, of course, as we saw in that diagnostic criteria, the hallucinations and even that REM sleep behavior disorder, where someone might wildly act out their dreams to the point they could even injure themselves or their bed partner, are very common symptoms here as well. So I think this is one of the most fascinating visuals to look at with this. And these studies were done by an amazing neuropsychologist in our Research Center of Excellence at the Mayo Clinic. And you'll notice the top set of bar graphs are people with Alzheimer's dementia. The bottom set of bar graphs are people with dementia with Lewy bodies. And it's their scores on the same cognitive assessments or neuropsychiatric batteries. So the red bars you see are test of memory, and you'll notice how much lower those scores are, those tests were, where folks had Alzheimer's compared to Lewy at the bottom, where the scores are much higher. And then those green bars are associated with scores of language. What I find fascinating here is not only are they different, they're kind of opposite. The score that's higher for the folks up top with Alzheimer's is lower on the bottom for Lewy and vice versa. When we move over to those scores of attention and executive function are in yellow, and you'll notice how much higher those scores are up top compared to for those folks with Lewy at the bottom. And once again, that opposite presentation in those assessments. And then another very characteristic cognitive change that we see with folks with Lewy body compared to Alzheimer are visuospatial changes. So the brain's ability to map where you are in space visually. And once again, notice how much lower and how much more impact there is on those folks with Lewy. And something I think is really important to point out here is on the far left of the graph, that black bar, that's the dementia rating scale. So that's just a global kind of screen or look at cognition. And that is where the problem lies. Look at how that score is completely the same. So for most folks, if they never make it past like a MOCA or a mini mental or something that just looks broadly at cognition, you're probably not going to be able to tell. And this is where these neuropsychiatric batteries really come in handy. You might have heard Dr. Fargo and I talking about that beforehand of, we struggle a lot of times with these issues with our own families of trying to get this comprehensive screening to understand what type of dementia it is. Because unfortunately, many clinicians out there still believe, oh, well, there's nothing you can do for it, so it doesn't matter what type of dementia they have. But I think as we go a little further into information, you'll see how important it can be. So with this, when we compare the initial cognitive complaint, so if you're just listening to a family member talk, or maybe you're a clinician and listening to patients, with Alzheimer's, you might hear stuff like, they're not really retaining new information. They're having those trouble recalling what was said or something that happened recently. They're repeating comments that you've made or questions, and you're kind of thinking, wow, we already had this conversation before. Here we are again. And when you compare that to what we hear from, care partners or people living with Lewy body dementias, a lot of times the first impact is in their processing speed and their attention. So they find that their thinking is much slower. We call that bradyphrenia, so slower thinking. So it just feels like the wheels are turning more slowly. They'll often report a lot of times losing their train of thought easily, difficulty with multitasking, kind of switching back and forth between types of tasks, and that causes difficulty keeping track of more than one thing at a time. So if people are still working, a lot of times issues will first come out kind of in their work performance task. You'll notice that visuospatial and perceptual. So you can imagine if you walk up to this aisle in the grocery store, how confusing it would be if you're trying to find the box of Total, on the shelf, because they'll have trouble seeing visuospatially, but the eye doctor says there's nothing wrong because it's not really as much about just that visual clarity or acuity. It's really once that signal goes into the brain, what the brain is doing to process it. So trying to find items in busy or cluttered areas, trying to maybe do repair tasks or assembly or hobbies that really have a lot of visual clarity. So important to note that the experience and what the person's going to report is often very difficult and different between the two dementias as well. So per those fluctuations, really important to note that this can sometimes look like delirium, especially if someone comes into the hospital, maybe, because their cognition can go from seeming very alert and awake, very coherent, they're able to concentrate and do tasks, and then it can drop down into this area where we see more drowsiness. They seem sleepy or zoned out. Maybe their speech is disorganized or out of context or less coherent, and they'll often, have a lot of trouble doing a multi-step task, or they lose their train of thought. And this can vary moment to moment, hour to hour, day to day. And so this can be very frustrating for families and care partners because they're experiencing this at home. Then they come into the clinic and they'll have what we call showtime, where all of a sudden they're completely alert and fine and talking to the doctor. And so this is something to keep an eye out. If you're seeing a lot of discrepancy kind of and variance in their cognition and kind of what's being reported, it might be these cognitive fluctuations that we see in Lewy. So I think you can tell from all that I've shown that it's just not the same. They might be types of dementia, but context, they'll say of Alzheimer's and other related dementias, I'd say it's not so related in a lot of ways. That loss of independence because of these symptoms appears earlier for folks with Lewy body dementia than what we see in Alzheimer's disease. The more rapid decline in functional ability and that increasing dependence increases the use of resources, right? So that contributes to that cost of care and to increased caregiver burden that we see compared for folks with Alzheimer's disease. And this is not to say that they have it easy either. We all know the burden and how difficult it is for care partners of those with Alzheimer's. People with Lewy body dementia generally have more severe behavioral or kind of mood, agitation, psychosis, hallucinations, delusions, those types of symptoms that really compromise their functional abilities compared to folks with Alzheimer's. And then another thing we get to throw in the mix with all of the changes to their motor or movement symptoms, we see a far greater fall risk and a shortened time from when they're diagnosed to when they start to have recurrent falls that can result in injury for those with DLB compared to those with Alzheimer's. And then I think when you can, wrap all of this up and put it in a package, there was a research study that suggested that men, at least with dementia with Lewy bodies, which we more commonly see this in men, progress to being admitted to a nursing home faster. And then once they're admitted, they have a higher mortality rate than those with Alzheimer's disease. So hospitalization, skilled nursing admission, things like this can be very dangerous. And so we want to avoid those things if possible, right? Currently, right now, though, the goal is to improve quality of life. Many of the symptoms can be managed or reduced with medications and other non medication strategies. But it's important to note that currently there are no treatments that stop the disease progression or cure the disease in any way. But we're definitely, I'm sure Dr. Fargo is going to talk about some of the research where we're working on that. So the management is all medical, right? And I heard an amazing researcher describe this as the Venn diagram from HELL. Not only do they have all these symptoms, they don't occur in a vacuum. They're all interwoven, they're interrelated, they trigger each other. If someone has more neuropsychiatric symptoms, anxiety, for example, that a lot of times may trigger some of the motor symptoms like freezing of gait that we see for people too. So they don't happen alone. And the management really, most of the drugs are used off label. We don't have drugs specifically for dementia with Lewy body. So a lot of these medications are being used from what we know in other conditions to manage the different symptoms. So very tricky diagnosis and very complicated medical management as well. And this adds into it as well because unfortunately they have a lot of sensitivities to medications in Lewy body dementia. And this, I would argue, is one of the most important reasons for having that accurate diagnosis. Many of the traditional antipsychotic medications, haloperidol especially, or Haldol, blocks dopamine and can be not only dangerous but deadly for folks with Lewy and also for Parkinson's disease. And then these medications can cause this neuroleptic malignant syndrome. So they can have severe fever, muscle rigidity, even kidney failure. And so even if they don't maybe, get to the point that they possibly pass away, they often need a higher level of care if they've gone into some kind of setting and been given these medications than when they entered. And another thing is the benzodiazepines even can lead to increased anxiety or worsen cognition. So this is why it does matter what type of dementia they have. We need it for medical management. We need it for safety. We need it to be able to really treat these and help support these families correctly. And then also some of the over-the-counter medications like Benadryl. You can hear it in my voice. I'm having a lot of allergies right now. So that Benadryl or that diphenhydramine can really impact people with Lewy. So we want to be very aware of what type of dementia they have and what medications to avoid. And so it takes a village. We know that they're going to need medical management, doctors, nursing. As an OT, I treated these families and helped them for many years with my PT colleagues, my speech therapy colleagues. There was so much we could do to support quality of life. Also, social work becomes tantamount. They really need that help and support. And sometimes counseling, psychiatry, psychology can also be really helpful. So it doesn't end with medical management. And with that, I'm going to hand it over to my colleague, Dr. Fargo, and I'm going to stop sharing my slides so that he can share and drive the ship himself. Welcome,
Thanks.
Dr. Fargo.
Yeah, thank you so much. I appreciate that. And give me just a moment here to figure out the share. Okay. So I think you can all see my slides now. Great. Thanks, Julia, for confirming that. And Julie did a great job of sort of telling you about LBD and what it is and what it's all about. And now we're going to transition over to sort of talk about what it looks like. Now let's talk about how do we detect LBD biologically. And a lot of progress has been made in this area in really just within the past 5 years in particular. Of course, none of that happened within a vacuum, and we were lucky to be able to learn from a lot from what's happened in the Alzheimer's disease example. So, with this being the Catasil Consortium, there are probably a lot of people on today who are familiar with some of this history, but for those who may not be, did want to take you through just a little bit of time on how we got to where we are with Alzheimer's and then how that's now also impacting and affecting what we're doing in Lewy body dementia. So you probably know that the Alzheimer's Association has been moving sort of from a clinical pathological definition toward a more biological definition in concert with the NIA and the FDA and others. They really started working on this back with the publication, actually several publications in 2011, which began to lay out some of the concepts of defining Alzheimer's disease biologically, including the concept of preclinical disease, which is something that the field kind of struggled to adapt to, I guess, for lack of a better word, for a while. But I think now we're starting to see that pay off with some of the approvals recently of disease-modifying medications. A really important concept that comes along with these biological definitions of disease is the idea of preclinical disease. And we're all very used to precancerous lesions. We're used to the idea that you might have high blood pressure and high cholesterol before you ever have a heart attack or stroke. And we're really now starting to think about even these dementia-causing diseases in similar ways, that the biology is already happening in many cases well before you start to see symptom number one. And of course, that is an opportunity for early intervention and to begin to think about prevention. So really first, the Alzheimer's Association and NIA started publishing on this in 2011. They updated their criteria in 2018, and then they updated again in 2024. So that's the most recent iteration, and that's the version of the paper that I'm showing you here. I think it's important to think about who all has been involved in this project. And one of the things that jumps out to me is that the leadership is multi-stakeholder. And that I think really is key because these kinds of things have to work for everybody. And so involved in this effort has been a nonprofit, mainly the Alzheimer's Association, the NIH, as well as FDA leadership, academics, and then industry. It is important, we think, to involve industry in things like this because if we're going to ultimately translate these kinds of advances into new medications and new diagnostics, it's really industry that gets us a long way down the road toward getting those kinds of things approved. But also critically, we think it's important to have the academics leading the way. And so in this effort, led by the Alzheimer's Association and NIA over the past decade and a half, really, one of the most important people in that has been Cliff Jack. And Cliff Jack is an academic who has studied this for a long time and is really seen in many ways as unassailable. And so that is important for this kind of thing, because at the end of the day, what we're really doing is following the science. If we follow the science, we're going to get where we need to go. And so that's the key, follow the science. Now, I'd like to actually point out a couple of things that I really appreciate about the Alzheimer's Association's framework around Alzheimer's disease. And that is that they're focusing on multiple different kinds of biomarkers and multimodality biomarkers. Now, obviously, the first thing we think of when we think about Alzheimer's disease are amyloid and tau. And of course, amyloid and tau do make up the key pieces of the staging framework and biological definition for Alzheimer's disease. But importantly, I hope you can see my pointer here, but importantly, we have, sorry, my phone was going off, neurodegeneration represented here as well. Inflammation represented here as well, and then some biomarkers of non-AD but important contributing co-pathology, such as vascular injury and synuclein. And of course, synuclein is the primary protein that is implicated in Lewy body dementia. So the Alzheimer's field is already starting to sort of reach out and start to include other kinds of contributing factors beyond just the very key proteins of amyloid and tau, which I see as a real positive. Let's see, they also have been doing some biological staging here. And so this is the biological staging, which I don't think is going to be too surprising to anybody, but we're essentially talking about amyloid and then tau later as you start to see some clinical decline as well and some functional decline. And then there's a clinical staging, and this clinical staging should really look very familiar to you if you've been paying attention to the recent FDA guidances that have come out, I'd say over really the past decade. They've really been building toward this kind of 6 or 7 step staging system, if you will, that goes from asymptomatic, potentially with a deterministic gene, all the way through fully blown dementia with severe functional impairment. And so that's sort of the common language these days of clinical staging with diseases that cause dementia. And then, of course, what the real goal of this is to put together an integrated staging system, an ISS, integrating the clinical staging along with the biological staging for really 2 reasons. Number one, earlier and accurate diagnosis, but then also to make sure that we're getting the right people in the right kinds of clinical trials at the right time, and that we're testing medications on people that there's a real chance that they would work mechanistically with the actual disease underlying their dementia syndrome. So it's important to know what is that biological disease if that's what we're trying to treat to alleviate the syndrome. So across the top here, you'll see the clinical stages, and then down the side, you'll see the biological stages. And in general, these match fairly well. So as you progress on in the biology, you're generally also progressing on in the clinical staging. But one of the things I'd like to really give kudos to the Alzheimer's Association for, because I think this is brilliant, and NIA, who've been working on this with them, is that they recognize that there is an above the diagonal and a below the diagonal as well. And in fact, there will be some people who are further along clinically than they are biologically. And there will be some people who are further along biologically than they appear to be clinically. So that's the above the diagonal and the below the diagonal. And they specifically call that out in this most recent paper that they published last year, or sorry, I guess it's been the year before last now. I'm still stuck in 2025. But here we are in 26, so this was in 2024 that they published this. And they mentioned that considerable individual variability exists in the population, and that's key. We've been doing a lot of talking today about sort of group differences between the diseases, which are important and are instructive and do help us think about what the future looks like and how we should treat these individuals. But it's also important to understand that tremendous variability. Folks who lie above the diagonal may have a greater average comorbid pathology. And comorbid pathology is really key. You saw in an earlier slide that I showed, synuclein is now being considered as a co-pathology with Alzheimer's disease, vascular as well, et cetera. And of course, there's FTD, there's TDP-43, you name it. There are many things happening in the brain of the average person with dementia that may be contributing to what they're experiencing. And, it's pretty clear nowadays that the quote unquote pure form of dementia is really the exception rather than the rule. And I'll actually show you some data on that in just a few moments here. And then, of course, there are also individuals who lie below the diagonal, and these are folks who may have cognitive reserve or resilience that keep their clinical picture better than what you might expect based on what you see with their underlying biology. So again, not to beat a dead horse, but I think that above and below the diagonal are really key pieces of this integrated staging system. Now I'm going to move just briefly to some biomarkers that are now available for Lewy body pathology. We tend to think of these really as being biomarkers both for Lewy body dementia, but also for Parkinson's disease, because they appear to work both for Parkinson's disease and for dementia with Lewy bodies and Parkinson's disease dementia, which make up together LBD. And so this particular test is called a CSF seed amplification assay, or CSF-SAA. We're just going to ignore right now in this image that there's also blood here, because people are working on getting this technique to work in blood as well as CSF. But right now, CSF is really the matrix that is furthest along with this technology, and it seems to be working extraordinarily well in CSF. But blood would, of course, be great because not everybody wants to get a spinal tap, which is understandable. So essentially the way this test works is you take a small sample of cerebrospinal fluid, maybe blood in the future, but for now a small sample of cerebrospinal fluid, and you put that in a test tube and you add in essentially synthetic alpha-synuclein. So these red dots represent synthetic alpha-synuclein, and this blue structure inside the tube here represents a seed. Okay, this would be an alpha-synuclein seed. And so it's these seeds that expand and then ended up creating the leading to the Lewy body formation later on. But if you have Lewy bodies in your brain, it turns out that you also do have a lot of these seeds floating around in your CSF. So we can put those seeds in the tube, spike it then with some synthetic synuclein, and then over days, actually hours to up to a week even, you actually shake this, break apart those seeds. You then allow the new synuclein to extend those seeds and lengthen them. And then you use essentially an intercalating dye to measure how long those are, because the tube will be more luminous if you have longer fibrils. And so then you shake that up and you do it again, and you extend those, and then you shake that up and you do it again and you extend that. And if anybody here has ever worked in PCR, you will recognize that this is essentially cyclic amplification the same way that you do with PCR. And it's a really clever way to make a measurement of how many seeds there were in the initial sample to begin with. Now, one of the things that I can tell you about SAA right now is that it can currently tell the difference between PD or LBD and controls, and it can tell the difference between PD and LBD and multiple system atrophy. And people are working on techniques to hopefully allow it to be able to tell the difference between Parkinson's disease and DLB, although I don't think we're quite there yet, but that is something that's being actively worked on. The other thing I should tell you about this measure is that at the current time, it's really binary. So it tells you you have a cutoff, and if you meet that cutoff threshold before a certain cycle number, essentially that says positive, and you have the seed competent synuclein in your brain at the time that we took the CSF sample. If it doesn't meet that threshold in a certain number of cycles, then that's considered negative. Also, people are working currently on making that a more quantitative measure, just like you have quantitative PCR and semi-quantitative PCR. So people are looking at things like the reaction kinetics to see if they can get that down to something that can reliably tell us about what's happening in the brain. I'll also mention here that there is now an in vivo biomarker for synuclein that uses skin samples. And essentially what they do is they look for the presence, using immunohistochemistry, look for the presence of phosphorylated synuclein in cutaneous nerves. And that phosphorylated synuclein in cutaneous nerves also seems to give us a clue as to what's happening with Lewy pathology in the brain. So you don't necessarily have to measure CSF. You might be able to get away with measuring skin. But didn't have the time to include an entire slide on that today, but did want to mention that that is also out there. Julia showed you earlier that even before the last few years where we've had the advent of these synuclein markers, there already were markers that were being used for diagnosis of dementia with Lewy bodies and Parkinson's disease, and one of those is DAT scan. So DAT scan has been in the diagnostic criteria for DLB at least since 2017. So with DAT scan, what you're looking at is the loss of dopaminergic synapses into the caudate putamen. And so that has been used, like I said, as a diagnostic for Parkinson's disease, and then more recently was also approved as a diagnostic for DLB. So this is not a new biomarker, but it does exist within the current clinical criteria, and is also being baked into what I'm going to talk about next, which is the biological definitions and staging schemes that are being developed for Lewy body dementia. So let's go ahead and turn to that. So in early 2024, February of 2024, there were two, I won't call them competing papers, but they're not exactly companion papers either, were both published in the Lancet Neurology. And each one of these is a report out of an attempt to create a classification system or a biological definition for Parkinson's disease. But they have both defined Parkinson's disease broadly to also include dementia with Lewy bodies. And so the paper you see on the left, this is a classification system that was developed by a team including Tony Lang and others. And it's called Synergy, S-Y-N for synuclein. That's the presence of synuclein with one of these new in vivo synuclein markers. Neur in EUR is neurodegeneration. So think about the N in the ATN framework for Alzheimer's disease. And then the GE is genetics. And that's in recognition of the fact that you can have a deterministic mutation and really have kind of, Parkinson's disease or LBD from birth in a sense, even though you don't have clinical or biological processes happening yet, they're detectable other than the presence of that deterministic gene. On the right, we'll spend a little more time here, maybe just about the last 5 minutes kind of wrapping up with this. On the right, this is a system called the Neuronal Synuclein Disease Integrated Staging System, or NSDISS. And so that's what I'm going to focus in on in the interest of time here. And a couple of things I want to show you about the staging system in NSDISS. One thing you'll see is it looks really similar to the staging system in Alzheimer's disease, and that's not by accident. A lot of the same folks were actually involved in putting this together. And you have clinical staging down the left-hand side, and you have biological staging across the top in this case. And I'll just quickly walk you through what I think are sort of the important pieces here. So you've got synuclein. So do you have a positive synuclein biomarker in this column? And in this column, this is that DAT scan, or do you have evidence of dopaminergic degeneration? Now, here's the key. And I want you to pay attention to functional impairment on the right, okay? So once you get to stage 2B, that can you must have synuclein present at that point, but you can either be negative or positive on dopaminergic degeneration, and you have no functional impairment still in this case. Then once you get to stage 3, that's the first time you're allowed to have functional impairment in this particular staging system. And in that case, every single stage, 3 and beyond, assumes that you have dopaminergic dysfunction. So, we have some questions about that. Is dopaminergic dysfunction really a measurement of neuronal degeneration, which should this really be considered a measure of N, the way it is, or the way you might think about neurodegeneration in the ATN classification system? And what about folks who do have synuclein and do have functional impairment, particularly dementia, maybe not in the movement symptoms yet, but can have full-blown dementia causing functional impairment? Really, we think that is possible in the absence of dopaminergic degeneration for people with DLB. Now, for people with Parkinson's disease, this seems to work fairly well. But we don't think there's enough data yet to say that this is really true, that you're never going to have functional impairment in DLB until you have dopaminergic degeneration. I will say this is a first pass effort. We are funding some research to develop more data to test these ideas. Michael J. Fox Foundation, Alzheimer's Foundation, NIH, others have contributed a lot of funding to pressure test this and kick the tires on this system because we think it has a lot to benefit it, to recommend it rather, and a lot of benefit to it. But it is a first pass, and the authors recognize that and are glad to have additional data to help us kind of kick the tires on it. I'm going to leave you, I think, with mixed etiology dementia here. And we've done a lot of talking about separating and differentiating Alzheimer's disease and Lewy body dementia, which I do think is important and good work to do. However, I would be remiss if I did not talk about the fact that there is tremendous overlap, particularly in dementia, particularly between Lewy body dementia and Alzheimer's disease dementia. And so you're seeing some of that on this slide, but what you're also seeing on this slide is simply how rare a pure dementia really is. So on the left, this is NAC data, by the way. And on the left, you're seeing the clinical diagnosis before death. And on the right, you're seeing what did the neuropathology show on autopsy. And if you look at the left, clinicians are making a call most of the time when they see dementia that this is Alzheimer's disease. Now, they may say, okay, well, there might be some mixed etiology in there. There may be some vascular, there may be some people even who don't have dementia at all here. But then when you look at the neuropathology, you can see the mixed etiology dementia really is the rule in the NAC data set. And when you look at the NAC data set and you look at people who only have Alzheimer's disease biomarkers when they pass away, it's only 7%. So we have 93% of the NAC database that is dealing with something other than pure Alzheimer's disease, and a lot of that is mixed etiology dementia. So that raises a few questions for us and has a lot of implications. And one of the implications, I think, is what does that mean for treatment with the therapies that are out today for Alzheimer's disease? We got aducanumab for a little while. That's off the market now. Leqembi seems to be better than that. Donanemab seems to be better than that as well. Both of those are currently on the market. We know that of people who pass away from LBD, somewhere north of 50% of them also had some Alzheimer's pathology. Could those people benefit from treatment with Leqembi or donanemab? Similarly, people who pass away from Alzheimer's pathology, 30 to 50% of them have Lewy bodies as well. So as we start to get medications for Lewy bodies, particularly those disease-modifying medications, we'll need to think about ways to test those in people with Alzheimer's disease as well. So my final slide actually is just, you may have heard, if any of you were at ADP last week or paying attention to the news coming out of ADP last week, There was an announcement. This is something that people in the LBD community have been waiting for, knowing this pathological overlap with Alzheimer's. But Lilly's going to be testing donanemab in a phase 2 trial of people who have clinical Lewy body dementia, but biomarker evidence of both Lewy body pathology and Alzheimer's disease pathology. And so we're really looking forward to the outputs of this trial. We're expecting this to launch sometime in late Q2. But we know how these things go, so potentially it'll go longer than that. But we'll be watching and doing everything we can to help Lilly fill this trial. So with that, I'm actually going to just finish up. If I can, I'll give the take-home points for both Julia and myself, and then we can move to the Q&A. So as far as some take-home points, clinical complexity, overlapping features, we do have new emerging biomarkers that are reshaping the landscape, and also starting to even inform treatment strategies. LBD progression is unique, faster functional decline, higher mortality, et cetera, compared to Alzheimer's disease and other dementias. But we are seeing these rapid advances in biomarker research that are opening new pathways for us. So with that, I'm going to stop and turn it over to the Q&A session now.
Thank you so much. That was really wonderful. Appreciation from all of us. I do have some exciting questions that I'm happy to dive into, and I tried to separate them. I think there's two for Dr. Fargo and two for Julia Wood. And if I get that wrong, feel free to pass the baton and have whoever's most appropriate to answer. So the first one for Julia relates to this discussion that you mentioned about cognitive fluctuation. And I guess the question asks how to address that discrepancy. So somebody had a parent who was locked out of their brokerage account because the broker noticed dementia and required a doctor's note to be let back in. But then when they went to the doctor, they did perform well and they got the note. And so the family's concerned, like, how would you address that? Would you tell the doctor this isn't what it looks like at home, or what do you suggest?
Yeah, I think that that's where, my experience clinically working with these families was, communication was really key with the allied health providers, with your doctor, with nurses, with everyone, because people really don't understand it. An example I'll give, we had a gentleman once who had an attorney over his estate. His wife had passed, and we had the hardest time helping the attorney understand, like, yes, he remembers all his friends, because a lot of people, I think when we talk about Alzheimer's not being all dementias, still most people believe that. So the attorney was like, he remembers all his friends. He knows everyone when he sees them, he's fine. And it took me doing a lot of different assessments kind of in front of them. And unfortunately, the gentleman pulling a live mouse off a glue trap for, I think, people to understand that, like, there's more going on here than just memory issues. And so I think that, keeping notes too, I think keeping some kind of a symptom tracker, dates, times that things happened, hopefully your loved one won't pull a live mouse off a glue trap, but keeping as much as you can about what's going on so you can communicate that clearly, with whoever you're talking to, because I think we still have to do a lot of education with providers, with people, to help them understand this condition. So great question.
Thank you. Question for Dr. Fargo, or possibly Julia, you let me know, but it relates a little bit to this overlap and the misdiagnoses that's possible. The question being how to obtain a proper diagnosis with regard to the type of dementia and the best medications. If you test for the marker for Alzheimer's, would it also pull up if there was Lewy body dementia present, or other types, or what is the approach you would take for getting the proper diagnosis and proper medications?
Yeah, those are great questions, and I welcome Julia's input as well. I think the main advice that I would give people is find a doctor that you trust, ask a lot of questions, and don't feel bad about getting a second opinion if you want a second opinion. These biomarkers, even for Alzheimer's disease, are still new, right? And if you go out into the primary care world, they're going to have a lot of questions, and you may have a lot of questions that those docs may or may not be able to answer for you. these in vivo biomarkers for synuclein for Lewy body pathology, the SAA and the skin biopsy. Those are even newer. So those are generally not covered by Medicare without doing a lot of work to get special dispensation. They're not covered by insurance companies right now either. You mentioned as part of that question, if somebody is testing for Alzheimer's disease, are they going to find Lewy body? And it really depends on how they're testing, right? If they're doing sort of a full suite of tests that includes, neuropsychological testing, that includes these new biomarkers for synuclein, that includes DAT scan, they're going to have a much better picture to make a correct diagnosis with. If you just go see your PCP and they give you the new blood test for Alzheimer's and it comes back positive, who knows? Maybe they say, well, you've got Alzheimer's, we're not looking any further. So I would say ask questions, keep digging, find a doctor you trust, and don't ever feel bad about getting a second opinion if you're concerned about your diagnosis.
Thank you very much.
Just love to add one quick, simple resource too that I think gets missed a lot, and it's called the Lewy Body Composite Risk Score. It was authored by Dr. James Galvin, and it's a quick, checklist that you can go through to kind of look at the risk based on the symptoms that you're seeing. So that's a great resource, I think, to share as well. And then also, we have a diagnostic symptom checklist on our website that's available for free, and also a comprehensive symptom checklist. So lots of ways to kind of look at that clinical presentation along with what Dr. Fargo was saying. I just think at this time, we don't have any clear biomarker where we can just rely on that. We have to still look at that clinical presentation, unfortunately, which I know can be confusing as well.
Thank you. Could you say the name of that resource, the initial one, just one more time?
Absolutely. It's called the Lewy Body Composite Risk Score. And I'm happy to send you the link as well if you'd like, if you want to share it out with others after.
Thank you. That's great. Okay, this question I think is definitely for Julia, relates to what you spoke about at the very beginning of your presentation with regard to, I think it had said something about Lewy body dementia being one of the most expensive dementias. Could you explain what that means, or just clarify or talk a little bit how that is distinguished from other types of dementia?
Yes, so that was based on a study. I can't remember the year. I believe maybe it's 2013, Keith, 2014. Do you remember, where they looked at some Medicare data, I believe from the state of California, and they compared among the dementias, the different costs. And Lewy body showed up as one of the most expensive and was related to really falls, psychosis, UTIs were another one. I think dysphagia fell in there. So a lot of the symptom complexity really related into, and also of course these medication sensitivities and antipsychotic issues. So I think we just got, and I don't know, Keith, if you can talk about this or not, but I know that we've been trying to recruit for people to do another study looking at the cost of this. So I don't know if you want to comment to that at all, or if you need to not.
Yeah, I don't think I can say that we just funded a grant recently to take a fresher look, because as Julian mentioned, that data is a little bit older. I do think it was maybe 2015. So we do need to take a fresher look at that. But but that was based on Medicare claims data and other data from that time.
Thank you. And I think this last question for Dr. Fargo, relating to the science and the research that's being done in this field, the question asks, will the science behind one help the others? And so I guess they're asking in terms of CADASIL specifically, but also other various types of neurodegenerative disease.
Yeah, I think so. One of the people that I listen to a lot when it comes to the pathology of dementia is Tom Montine. And I think a lot of people here probably are kind of familiar with his wisdom. And one of the things that he talks about is the conspiracy of 7 proteins, right? And potentially even more, than that at this point. But there are lots of things that can start to go haywire in the brain as it ages, and those and it's probably not just a one-to-one relationship either, right? I mean, we talked about how Lewy pathology can lead to different kinds of symptoms than Alzheimer's pathology does, and they can look different. But we also talked about that overlap. And one of the things that I like to point out to people with the overlap is that, you know, the percentages are much higher than you would expect by chance. You know, we think about 30% of people are going to have Alzheimer's, you know, at some point in their life. But if you look at people who died from Lewy body, it's 50 to 80%. You know, there's probably something mechanistic happening there. And so I do believe that the more light that we can shed on all of these proteinopathies and vascular contributions and genetic contributions, you know, thinking about CADASIL and others, I really do think it's all just part of uncovering the full puzzle, if you will.
Thank you very much, both of you. I just personally appreciate the generosity with which you share your expertise and your work in this field to advance the science, which will hopefully, as you say, provide answers and kind of, you know, help conditions across the board. So we are hopeful and grateful to you, and thank you so much for being with us.
Thank you for the opportunity. We appreciate it.
Okay, have a great
Absolutely.
evening, everybody. Look forward to seeing you next month.
Thank
Bye-bye.
you all.